We have a very cute little 2-year-old golden retriever who has a history of ingestion of a foreign body. It was at a friend's house. Can I get cautery plugged in, please? Or is that in? It's not working at all.
Well, do you want to check the front plate?
Ish. Maybe I switched to, instead of soft coag, let's switch to blend. So ingested a foreign body. See where it's a soft coag there. Surface coag, try that. And is that in monopolar 1 or 2? 1. See if that works better. Yeah, that's better. Anyway, 2-year-old golden retriever. Went to a friend's house. They had kids. There were kids' toys all over the place. And so she ate some toys and vomited it up one ball. Just be a little bit aware. I think we're waking up a little bit. And then an ultrasound confirmed that there were more foreign bodies in the intestine, and under anesthesia I can actually palpate one of the balls in the intestine. So we are doing an XLAP. Really important thing here is to make sure that we do a complete exploration to make sure that we don't just stop with the first foreign body we see and miss something else. Got a little bit paramedian here. If you haven't already done so, love you to subscribe to our channel and turn on notifications so you'll get a ding on your phone the next time we live stream. So key things with an XLAP is make sure that you make your incision long enough so that you can see everything that you want to see. And we're going to use laparotomy sponges instead of gauze squares so we don't leave anything in, and also they're much better at, I think, gripping tissue and absorbing blood. So long enough incision. The other thing we want to do is remove the falciform fat. And we want to use Balfour retractors to make sure that we can see. And then we're going to do a systematic, complete exploration to make sure we don't miss anything else. Diaphragmatic hernia or another foreign body or a weird tumor or something. We've got one chance to look at everything in this belly, so we want to make sure that we take advantage. I don't use laparotomy sponges to pack around the linea. I was trained in that fashion, so I'd just go ahead and put my Balfour straight up against the abdominal wall. I think there's a problem doing it either way, but that's the way that I was taught. Just extend this just a little bit farther back. And might just zoom in a little bit more. And I always, a mental patch, as somebody has noted. I don't use staples. I always do mine hand sewn. I think I'm pretty quick with hand sewing, and I think my results have been better with hand sewing. I have done staples before and just not that satisfied with the outcome. So I'm up here looking at the liver now, looking at the diaphragm, making sure that there are no hernias, no masses in the liver. I'm going to express the gallbladder. So gallbladder is expressing easily. I'm going to palpate the stomach to make sure there's nothing there that was missed on an ultrasound. I'm going to lift up the duodenum and you make a duodenal basket. Put all the guts up behind it. I already see the foreign body there. All right, so we can see the vena cava right there. The kidney. We've got quite a bit of clear fluid in the abdomen. Coming around the caudal duodenal flexure into the jejunum. Finding my way around that caudal duodenal flexure. Remember, we can't exteriorize the caudal duodenal flexure because of the duodenal colic ligament. Those intestines look a little bit inflamed. So the foreign body has run through all of this tissue already. Now, this is twisted a little bit. Okay, so there's one foreign body right there. That's really erythematous right there. And then we've got another foreign body right here. Possibly another one right there. So we've got two foreign bodies here. All right, and we'll just keep palpating. That all looks nice and healthy. That has never seen foreign bodies, so that's going to be really happy. There's the antimesenteric vessel right there, which tells us that we're in the ileum and the cecum. And now we are into the colon. Colon is pretty empty. Lift the spleen out. Have a look at the left adrenal gland, which is right there, normal in size and appearance. You can see the phrenico-abdominal vein sitting on top of the adrenal gland. All right, so we'll go back to this loop of bowel. Let's go ahead and pack all this off now so we don't get any leakage. Looks like a pyometra. All right, so this is our affected bowel loop. And ideally, you don't want to incise right over where it's really inflamed. I'm going to try to milk this up. You can hear just the ingesta squirting through. So I'm going to try to milk the second foreign body up to where the first one is so I can do just one enterotomy. So now I've got all the foreign body packed together there. Let's get some more lap sponge, please. Just pack that off there. All right, so we'll hold that up like that. See if there's one place better than another for me to. All right. Can I get some 3O PDS, please? There's a question about attending a workshop that I'm giving in March in Sydney and whether that would give more confidence doing axial pattern flaps, and yes, it would. Well, that's the intent. Can I get a couple more hemostats, please? A couple more hemostats, please, Mia. Thank you. I'm just going to come up here. And just lift those out like that. Okay, we'll drop that down a little bit. Do you want to come around here and just get the suction ready? All right, so I'm just going to incise right through onto that foreign body. Not sure what this is.
Yeah, I'm holding up.
Don't know what that is.
Something squishy. I'm gonna try it already.
That is very strange looking. Don't know what that is. Squeeze that out through here. Keep suctioning. I'm not sure what those are. They're not pretty, whatever they are. Okay, so now we'll just keep that stretched out here. Zoom right in. I have not used bowel clamps. Certainly could have. I didn't feel like there was a lot of fluid there if I was concerned about fluid. Doyen intestinal forceps would be a good idea. All right, so now I'm going to do a simple continuous suture pattern. You can drop that. Just hold on to that one. So now I've dropped one of the stay sutures. Move that other direction. That way, yeah. I don't put them on metoclopramide, typically, unless we have evidence that they have ileus. All right, so now I'm going to do simple continuous suture pattern, and each time you'll see that I'm going to release that stay suture and then grab onto the loop and replace it. And you can put a little bit more tension on that, please. My bites are going to be about 3 millimeters apart and about 3 millimeters from the edge. Bit more tension. And I don't typically leak test my anastomoses, or my enterotomies, but what I will do is I'll probe with our hemostats and make sure that I cannot sneak a hemostat in between the sutures. Down a little bit. Sorry. Yep. Question about whether I do go full thickness on these. Another question about whether the Onc Fellowship was valuable. For me, it was extremely valuable for me. Changed my life, but changed certainly the way that I approach cancer, and it actually gave me kind of a real anchor, so that when I started my practice in Virginia, my first hospital, I had something that I could really promote that was a niche area of expertise of mine. Plus, I met some really great people. So if you are offered the Onc Fellowship, it is extremely worthwhile to do. A little bit shaky. I haven't had my lunch yet. Let's just pull that up a little bit forward. Yep. And you see how I had Cindy keep tension on the stay suture the whole time. And that's to make sure that my sutures aren't loose. That's, I think, a really important potential cause for leakage after intestinal surgery, is having loose sutures. Can I get some more 3.0 PDS, please? So now I'll just go back and have a look here and see if anything looks obviously like it's too far apart. Done a pretty good job there. So let's grab a hemostat, and I'll grab this with a right angle. So now we're going to take our hemostat and we're going to probe I can get through there. So I'm just going to take another bite right there. And I'll do another one just caudal to it. Thank you. So leak testing, you can make anything leak, basically any intestinal surgery leak, if you put enough pressure. And what they have found is that probing is actually more predictive of leakage after surgery than leak testing. There's one more that's a little bit far apart, farther cranially. So serosal patching is basically, I do serosal patching if I'm worried, and I do omental patching in every case. So serosal patching is actually if I'm concerned about a leak or the integrity of the intestine, whereas omental patching I do every time. I'm not going to do a serosal patch here because I don't need to. But basically what you do is you're making a patch with adjacent intestine. And that's been shown to be very effective at reducing leakage. Now what we're going to do, what's that?
Can you flush?
We will flush. So where is the omentum? So we'll just bring some momentum over the top here. And I like to suture my omentum in place. I know some people just lay it on there, but I figure I'm here, I might as well give it a head start. So I've got just a bit of omentum that I've put over the top here. And your omental patch sutures, it doesn't matter whether they go into the lumen or not. And I'll just leave that one long. And I'll come back and tie to that later. We'll put a little hemostat on there. And so doing another layer of simple continuous in the opposite direction, I don't think it's necessary if you're happy with your probing, and I'd be concerned about that additional layer potentially compromising the blood supply to the edge. And so I generally would not do that unless I'm really concerned, like unless I've got a reason to. Can we get some warm flush, please? And this dog will not be on antibiotics after surgery. We gave a single dose during the surgery, but there was no leakage here. I was well packed off and stuff, and so there's no indication, in my opinion, for keeping this dog on antibiotics post-op. There was no peritonitis at the time of surgery. All right, so we'll go ahead and lavage and get out of here. You can see how nice that looks with our omental patch on it. another question about whether you can pexy the intestine to the abdominal wall. I think there are better ways to do it. I'd rather do a serosal patch than to pexy to the abdominal wall. We get, what's the biggest suture we've got in here? Oh, PDS? Yeah, we'll take that. Okay, so now we'll just do our linear closure. Just making sure that I'm getting the actual linea alba or the external rectus fascia. Leave that tag long, please. Thank you. So managing peritonitis after surgery, it's going to be getting in there, flushing the abdomen really well, making sure that we remove any fibrin clots, correcting the underlying cause of peritonitis, and then depending on the cause, and the extent of peritonitis would determine whether I'm going to do a drain. So if I'm moderately concerned, I'll put in just a regular Jackson-Pratt drain into the abdomen, and then we can flush it every day and suction it back out. I would not put the bulb on the Jackson-Pratt catheter because, or the Jackson-Pratt drain, because the bulb, when you first deflate the bulb, it generates about 50 to 100 centimeters of water, negative pressure, which is too much, and you'll get potentially barotrauma to the intestine. I would just intermittently suction that. And then if I'm really concerned, you can do open peritoneal lavage, which is a big deal. Like that's a massive jump in management intensity, because they're going to become very hypoproteinemic, dehydrated. You have to anesthetize them every day to flush out the abdomen. I've only done a few of those. In my career, mostly I just manage them either by lavaging and then closing, or putting in a Jackson-Pratt drain.
Can we get some bupivacaine, please?
And again, as I'm doing this simple continuous suture pattern, you see how Cindy is keeping tension on the suture for me so that it doesn't loosen. And so the question is, so I do a suction every 4 hours. Depends on what I'm trying to, if I'm doing it diagnostically, it'd be every 4 hours. I think probably if I was doing it for peritonitis, I would probably suction it every 4 hours as well. And then twice a day, infuse warm saline and then suction it back out.
Yeah, what is the dog weigh? 30.
So 12 mil. Cindy, are you happy doing the line block?
Sure.
And just make sure that we're going all the way forward, all the way cranial on our linea closure. I have had cases that have developed a little hernia at the cranial end of my incision because I haven't gone far enough forward. So I'm going to go and have a look and make sure there aren't any questions that I haven't answered. I'm going to leave that quite long. Let me just make sure that that's tight enough. Okay, and no meloxicam in this dog after surgery. Okay, and you do not include the full thickness of the muscle. When you're closing, all you close is the external rectus fascia. We've got Cindy doing a line block with bupivacaine. So bupivacaine is all we use here for the most part, unless we need something quicker, which is then we use lignocaine or lidocaine, because that is going to take effect in about 10 minutes, whereas bupivacaine can take 30 to 40 minutes. Just looking to see if there's anything else. Merry Christmas, everybody. For a toe fracture, if it's just one toe and the toe adjacent is intact, then often we will bandage it unless it's really displaced. If it is displaced, you can cast them. If it is displaced, you do want to get that reduced before you cast them. If it's really displaced and you can't reduce it, then you probably ought to go in surgically and go ahead and do a pin. Yeah, so that whatever was in there was kind of like silicone or whatever. Fellowships are very competitive. CSU is a great place to go, although I'm sure that there's some really good ones other places in the US and in Europe. Hi, Toronto. Portugal, Mexico, Colombia, UK. All right, so just go back to the bottom, make sure I haven't missed anything. All right, so in Mexico City, I don't think, I may have a live stream today. I don't think I do, but I will have to see. I've got one case that's getting a CT scan, probably just electric chemotherapy, but if we go to surgery, I'll try to live stream that as well. All right, if you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. And if you know of anybody else who'd be interested in this kind of stuff, please